So, welcome again to another episode of the School at Airway. I do a lot of teaching regarding trauma, simulation, and airway at the place I'm at the shop that I work at. Wanted to show you that we need to update some ideas on airway and update maybe some surgeons on alternative management on airways. So, this is what I got from the American College of Surgery 2002 guidelines on a poster presentation. And on this, it talks about the management of airway. Okay? Now, it says 2002. Is this information up to date? Illustrations from 1997. Okay? So we need to update how we teach and what we teach to our residents. Okay? So, again, we're all taught this idea about a definitive airway, recognizing a need for emergency airway. Are you protecting airway? Protecting the patient from himself? Is the patient apneic? Does he have a partial or complete airway obstruction? Is it urgent? There are many indications for intubations. Okay? Am I providing adequate oxygenation or ventilation to this patient? If I don't do anything, if this patient is spontaneously doing it on his own, most of the time when the GCS drops, I'm trying to prevent aspiration. I'm trying to protect his cervical spine from being further injured when he's altered and has a mechanism that explains possible neck injury, C-spine injury. All right? Hey, maybe an urgent intervention. This guy can be a multi-trauma with many disastrous injuries, and he's combative, and he needs an emergent surgery. He needs to be intubated anyway for the surgery, and you just need to intubate him for that. Combative patient, can hurt staff, can hurt himself, right? And, hypoventilating or hyperventilating, using accessory muscles, nasal flaring retractions, flailed chest, paradoxical motions. These are things you see on exam, all right? We stink at the simple things like a jaw thrust. I don't even do a chin lift. I don't know if a patient has a broken neck. Jaw thrust, I can do it on any patient, broken neck or not. OPA is bad. If they gag, they will aspirate. You will see how vigorous or aggressive that gag reflex of the patient is. Nasal trumpet, aka the nasopharyngeal airway, not great if you have epistaxis or suspect mid-face injury, or no one wants to be the person who puts this in and gets a CAT scan that shows it's traveling through the cervical plate into the brain. In medical school, we're showing a picture of this with the no G-tube coiled in the head. Patient must have had a massive headache. Definitive airway, nasal, no longer taught. It used to be a blind technique. Even in skilled hand, 50% fail rate. At that time, we thought that maybe putting a seat collar on, protecting the neck, and it was more likely if you intubate through the nose, he wouldn't cause more cervical spine injury. But the patients would be partially awake. This is an awake intubation through the nose, and the patient would get iatrogenic epistaxis. Patient would move his head around because it's very uncomfortable. This is not a small hose. It's the largest tube that fits the nose, 7.5, 8. Uncomfortable. Oral intubation, patient has been sedated, or already his GCS is so low that you're going to intubate. If you think he's near dead or dead with no pulse, you don't need to give medications. All right? And if he is kind of awake and moving about, clamping down on the jaw, you have to give him medications like RSI. If his stomach is not full of food already, it's full of blood, maybe from the trauma. Okay, so you need to prevent aspiration, you pre-oxygenate. Critical pressure does not really help. I'm not a wanker, I don't believe in this. What I do believe is topical anesthesia, no. It's sedation and muscular blockade as needed. If he's hypotensive, give ketamine. If he's hypertensive, very rarely that's going to happen with the patient in true traumatic shock. If he's young, he'll handle the tachycardia that happens with ketamine and the surge of hypertension that happens. All right? That's acting almost like an IV push dose pressor for me. Okay? Muscular blockade, sucks a lot of times. I don't know how long he's had the injury. Hopefully not more than 12 or 24 hours after the injury. All right? I don't know his baseline creatinine function or his kidney function, if he has nephrotic syndrome or kidney failure. I'd probably give rock. Can't wait for the generic brand version of Sugammadex comes out in maybe 5-10 years. All right. Adequate visualization can be assisted with video laryngoscopy. That's why this poster has to be updated. All right. If you think it's going to be a difficult airway, get your suction ready. Suction as much as possible the airway, and then don't dip the blade, the tip that shows the wonderful view that you want to get, into ragu sauce. This is not an intubation underwater. Okay? I'm not intubating through the nose unless I have a fiber optic scope. But if the patient's lying flat, he's just pulling secretions, blood, with or without blood, it's the enemy of fiber optics. It's going to sow the tip and I won't see anything. You know, you can ramp these patients. You can put these patients in reverse Trendelenburg. You don't have to bend the bed. All right? With our modern stretchers, you can do reverse Trendelenburg. Keep them upright. If you're worried about the neck and the seat collar, don't give them to the edge of the bed, but at least position the head above the stomach. You can try your best to do interstitial knowledge to prevent aspiration. But guess what? If this fails, everyone believes the alternative is a surgical airway. If the SATs are dropping, a surgical airway will eventually get the SAT up. But if you do it too late, maybe too late. All right? So the issue is this. Most of us do not have a gent ventilator. Most of us only have a syringe. We'll try to connect it to a 3cc syringe, connect it to 7.5 or 7.0 ET tube connector to a BVM. Good luck on bagging. I don't care if it's a 12 or 14 gauge. It's not going to work in maintaining oxygenation. A gent ventilator is required. A jet ventilator. Or this new Entran device that just came out that proves that through a needle you can oxygenate. It just came out. All right, it was in at the WAM conference, World Airway Management Meeting Conference this year, 2015, in Dublin, Ireland. All right. If you can do a surgical airway, use a bougie. I would not advise a needle crike. Use a bougie. Extend your finger. It's better to use a Shiley, size 4 or 6 Shiley. You can use an ET tube. It's accessible. Use a scalpel. Use a bougie. Use what tube you can get. All right. The smaller Shiley won't fall out. Won't get tugged and pulled out. Just my advice. If the patient's obese and you don't get any anatomy, vertically cut. Vertically cut. Then commit to the horizontal cut after you feel and bluntly dissect with your finger or the back end of the scalpel where you're going to do the horizontal cut. And once that happens, you can use a blunt end to opening up that membrane as much as possible. Throw that bougie in. Don't lose that airway. Push that bougie down to the carina. Maybe you'll hear some ladder sensation of like feeling the tracheal rings. But what's going to convince you is the hold up at the carina. That bougie will disappear if you're in the esophagus if you cut too deep, which is very hard to do. It's a cartilaginous cage. Almost impossible to cut through with a scalpel. Okay? But guess what? If you failed your oxygenation through BVM, after you did intubation or an attempted oral intubation, you can use an LMA. It's actually in the shock trauma algorithm. Can't bag, SATs are dropping, throw in an LMA. You have two options. Do a surgical airway in the theater, operating room theater, or do it right there with the controlled setting of you oxygenate the patient with a LMA. Now you can actually, in a controlled way, provide oxygenation, rescue breaths, and do the surgical airway in a controlled manner. I would advise the King LT. It's a little bit more invasive, a lot better when you have soiling with blood and gastric contents if the patient already threw up or aspirated, or if they're actively bleeding. Okay? Again, the King LT, in my opinion, is better than the laryngeal mask. Laryngeal mask is better than the BVM. Both higher end, more expensive devices, but they will save the life of your patient. And is that not the person that we care about the most? Not the wallet, but the patient? Again, I'll welcome you to part 2 of Airway in Trauma. But again, we need to update our information, not from 1997. It is almost 2016. Almost 19 years has passed where these illustrations were borrowed. And this post is from 2002. We need to get with the new technologies. Okay? Thank you.